All right, continuing, jumping into it, and then we'll have a short break, a little bit of a longer break after this next talk. Our next speaker is going to be Dr. Tara Scott, class of 2005. Dr. Scott has been core faculty here at our residency since completing her residency, so almost 20 years now. Within a few years, she became the assistant program director and now has been our program director since 2017. In fact, shortly after assuming leadership at our residency, Dr. Scott, Santa Rosa, our Sonoma County community, experienced a devastating wildfire, and Dr. Scott was really instrumental in how our program not only survived, but really thrived after the fire. So big kudos to Dr. Scott for how she led our recovery after the fire. Dr. Scott is proud to be a physician and a teacher. She's an active teacher of women's health care and hospital medicine. She's a fierce advocate for women's health and reproductive rights, and has been working in our residency practice and at Planned Parenthood for nearly 20 years as a teacher of abortion care. So Dr. Scott will be talking with us today about abortion care in 2024. Tara, please take it away.
Thanks, Douglas. It's so great to see all of these names on the screen. I was wondering who would be at this pregnancy care conference and whether there would be people with experience in abortion provision. And given the number of people who've come through our program, I can already tell at least that many people that are present today have already been involved in abortion care. And I was thoughtful about how to integrate a talk on abortion into a pregnancy care conference, and wondering what I could bring to a group of people who are already very likely doing pregnancy care, some who may also be doing abortion care. And given the likely level of expertise, I am going to focus on medication abortion for a couple of reasons I'll explain. But it was challenging to figure out how to get a talk on abortion in 2024 in post-Dobbs America into 30 minutes. So we'll see how I can do with that. I'm going to switch over. Folks able to see my screen? Before jumping in, I just want to highlight that for me, as somebody who has not done pregnancy care since I was a resident, something I absolutely love to do, but has been doing abortion care since I was a resident, that providing care for patients who have poorly timed, undesired, unsafe pregnancies has been one of the great joys of my practice. And I really want to just highlight the joy of abortion care. There's so much politicization and stigmatization of abortion care. And I just wanted to hopefully my joy in practice in caring for patients who decide to end a pregnancy comes through. But I also just wanted to highlight that for anybody who's considering maybe stepping in. And you'll see that I have an agenda. I will just tell you that if you're in a state that isn't currently restricting abortion and you have the possibility of becoming a medication abortion provider, part of my agenda today is to maybe pick your interest and make you start to think that you could incorporate it into your practice. So the objectives for the talk, you can see, are going to mostly focus on medication abortion. I'm hoping that after the talk, you'll be able to distinguish between a 1-drug and a 2-drug medication abortion regimen. Probably most people are familiar with the mifepristone and misoprostol, but I wanted to highlight the availability of misoprostol-only regimens. Also, that you'll be able to compare the efficacy of a single dose or repeat doses of misoprostol that are used in the 2-drug medication abortion regimens. I wanted to highlight some really high-quality training and support resources for providers who are considering incorporating medication abortion into their practices. And also that you'll be able to access at least 2 online resources for patients who are looking to independently access abortion care if you are in a state where you're unable to provide and they're unable to travel out of state. So I just obviously briefly have to touch on politics. This is an incredibly political time for abortion. As you probably all know, in 2022, the Supreme Court, through the Dobbs versus Jackson decision, essentially overturned the protections for abortion that Roe v. Wade had assured people in 1973. As a result, nearly 18 million people with the potential for pregnancy no longer can access abortion care in the state that they live in, and in many cases, in the states around them. And just thinking about who this is going to impact the most, the majority of people who have abortions are young, under 30. About 3/4 of people are under 30. Also, the majority are unmarried, although there's also about 1/4 of people who are married who seek and get abortion. And also those living in poverty are most likely to need an abortion and also to not be able to access it in their state. People who identify as Black or Latinx are more likely to get an abortion and are also than people who identify as white. And it's those same people who are less likely to be able to access contraception. So the laws really are impacting, they're reinforcing many of the social drivers of health that we already know impact people's health. And interestingly, in spite of the many, many restrictions that have fallen since the Dobbs versus Jackson decision, there is early evidence that abortion in the US is increasing. And that's what we're going to talk about. But just looking at this map of the states over here, the dark red and orange states are most restrictive. So since Dobbs, 14 states have enacted total bans. 7 states have enacted restrictions that would have been considered illegal under Roe v. Wade on any type of abortion. And some of the ways that states restrict but don't have total bans on abortion include things like how many visits are required, whether consent is required for minors, how many, who can provide an abortion? Is it only a physician or advanced practice clinicians able to provide the interval between visits and how many visits are required? So there are many, many ways that states can lay in barriers that are essentially like bans. And then if you look at the dark blue states like California, things that states that are moving to make abortion protected include things like shield laws, which protect providers who are doing telemedicine or sending medication across state borders. Making provisions for advanced practice providers to be able to provide abortion services, making sure that Medicaid and private insurances are required to cover abortion.
I gotta do my hair.
So just wanted to lay that political landscape and also say that probably one of the reasons why we're seeing a rise in abortion, certainly the states that are adjoining the states with complete bans, they are seeing anywhere from a 75% increase to, in New Mexico, they've had a 220% increase in abortion business because they are close to states with total bans. So not only are states near other states with total bans having increases, but what happened during COVID was that telemedicine abortion became a reality. And it was kind of perfect timing for Dobbs because now all of those provisions that were put in place for telemedicine abortion have become utilized for patients that are living in states with total bans. So like I said, I'm going to focus on medication abortion, but I wanted to just highlight the overall safety and effectiveness of both medication abortion and procedural abortion. And it's difficult to get both efficacy and safety data because it really depends on whether you're talking procedural or medication abortion. It depends on the gestational age. So these are my best, this is my best effort to sort of bring together some data about safety and efficacy. Looking at medication abortion under 11 weeks, it's extremely effective, somewhere between 80 and 100%, but I will say in the United States, where a two-drug regimen is widely available, we're really talking about upwards of 93 to 100% effectiveness. Any complications with medication abortion are rare, and death from medication abortion is exceptionally rare. These data were from 2006, but essentially medication abortion is a death from a shot of penicillin is twice as likely to cause death as a medication abortion. So I think many of us would feel comfortable getting a shot of penicillin if that was the appropriate medication for an infection that we had. Looking at procedural abortion in the first trimester, highly effective, over 99% effective at terminating pregnancy. Any complications are still rare, about 6.5%, with the majority of those being the need for a second procedure, either to remove a missed pregnancy or to remove some products of conception that are causing bleeding or from infection. So overall, incredibly safe with low complication rates and exceptionally low death rate in the setting of legal procedures, usually having to do with adverse reactions to anesthesia, pulmonary embolism, more rarely infection or uncontrollable bleeding. And just to highlight, since we're at a pregnancy conference care, that procedural abortion is 10 times safer than continuing with pregnancy, something that I like to highlight for patients at the time of procedure. So why did I choose to focus on medication abortion today? This slide shows that since the beginning of the FDA approval for medication abortion at the beginning of this century, medication abortion has become a greater and greater proportion of all the abortions that are done in the United States. So leading up to 2020, before COVID, it was sort of just reaching over half of abortions. And then now with the advent of telemedicine and the total bans in 14 states of the United States, medication abortion, although the data is really not out yet, it's very likely that medication abortion is going to become an increasingly large portion of the abortions that are received in the United States. So I wanted to focus a little bit more on those. And also because if you aren't already providing procedural abortion in your practice, I thought it's unlikely that a talk I could give you today would have you start doing procedural abortion, but that you may be able to consider incorporating medication abortion into your practice. So just briefly, there are really only two medications to know about when we're talking about medication abortion. The first is misoprostol, which most of you will be familiar with from labor and delivery. It's a prostaglandin analog, and it was first found as a way to protect the gastric mucosa, in particular from NSAID-related ulcers. And it also causes contraction of the smooth muscle of the uterus and the GI tract, which we take advantage of. Contraindications are rare, and just really a previous allergic reaction to the medication would be the only contraindication. It's very available around the world. It's available without a prescription, which is why people access it for self-managed abortion. And it's also very inexpensive. Next up is the famous mifepristone, originally called RU486. It is a progesterone receptor antagonist, so it interrupts the connection of the early pregnancy with the uterus. It is FDA approved in the United States still at this time, up to 10 weeks, although I will say it is also used by patients who are doing self-managed abortion at much higher gestational ages. And in our clinic, for instance, it's used up to 11 weeks with a little bit of change to the regimen. So officially, it's approved for use up to 10 weeks, but can be used much farther. The contraindications to mifepristone, again, like any medication, a previous allergic reaction, having an IUD in place, having a pregnancy of unknown location, chronic adrenal failure on steroids because it can interfere with the steroid axis in the adrenals. And mifepristone has had some very sometimes challenging to overcome barriers. In order to prescribe, you still need to be a certified prescriber. And at one time, it was required for us to physically give and watch the patient take the medication in the office, although that is no longer the case. Now there are provisions for certified pharmacies to be able to dispense mifepristone as well. The price of mifepristone, we commonly talk about it being $100 a pill in our clinic here, but I saw online anywhere from $50 to $800 for a mifepristone pill. And then the other thing to think about for medication abortion is analgesia. I never like to forget about just good old-fashioned hot water bottles, which are nice for cramping. And then the majority of patients can be reasonably comfortable with NSAIDs or Tylenol. The CDC came out a few years ago, sort of to address our opiate epidemic, recommending a very limited number of opiate analgesics like hydrocodone or oxycodone, if you consider that that is necessary for the patient, something like 5 pills. I want to highlight how achievable it is to do medication abortion in regular practice. You don't need a lot of special training. I think you'll see from these items here that these are things that anybody who is doing pregnancy care can already do. To assess somebody for a medication abortion, you need to be able to clarify the gestational age of their pregnancy. You can just use the patient recall of the last menstrual period. Some studies showed that if we just use patient recall of a sure LMP, that a very small percentage of people would be beyond the recommended gestational age for medication abortion, but it's still very effective at that, at those higher gestational ages. So really, it's not as much of a concern as we might think. And you can also do that through, determining when the onset of their symptoms was. You can use office ultrasound, although during the COVID pandemic, we saw really for the first time that ultrasound was not being used as a way to determine eligibility for medication abortion. So if you have ultrasound and can do that, that's great, but you can also do it without. You need to assess the patient's risk for ectopic pregnancy. I'm sure that all of you know how to do that, either through symptoms, also thinking about their history of previous ectopics or previous PID, and whether they have an IUD in place, which might increase the likelihood of ectopic, which would also be a contraindication to medication abortion. And then also just thinking a little bit about the medical history. Really, you just need to make sure that patients don't have a bleeding disorder or that they're not using chronic steroids, which I have very rarely encountered in our practice. And then determine if they have a risk of RH sensitization. Although, as it's already been talked about here, recently we have historically, we gave RH to everyone. I mean, Brogam to everybody who was RH negative in our practice. And now we're moving towards only giving it to patients who are over 12 weeks. And that's really more relevant for procedural abortion since we're not knowingly giving patients medication abortion over 12 weeks. And then you want to assess for allergy. So something that I learned about through preparing this talk is that there have been really huge shifts in prescribing and delivery of medication abortion, like I said, since the COVID pandemic. And also recently, the FDA made provisions for pharmacies to be able to, certified pharmacies to be able to carry mifepristone and deliver it to patients just like any other medication. So the ways that you can prescribe medication in abortion, specifically mifepristone, are that you yourself become a REMS a certified provider through Danco who makes mifepristone. It's very easy. It's a one-page form, and you basically become a certified provider that way, and you can keep pills stocked in your office. They're expensive, and that might not be feasible for people who aren't doing this frequently in their practice. So another way that you can do it is still as a certified prescriber, you send a prescription to a certified traditional local pharmacy. Even though the FDA said that pharmacies could dispense mifepristone, obviously that is not the case in states that ban abortion. But even in states where abortion is legal and supported, pharmacies are really still trying to figure out, the big chains are trying to figure out if they can do this without political blowback. There are some brick and mortar pharmacies that carry it. I heard there's one in Sebastopol here that carries it. So you can just prescribe it like any other medication to the pharmacy. The patient goes and picks it up and then follows your directions. The thing that I just learned about that's kind of exciting is that there's also Honeybee Pharmacy, which is a mail order pharmacy, is integrated into many electronic health records. So if you were going to prescribe medication abortion through Epic or another electronic health record, you can actually search for Honeybee Pharmacy, and you can send your medications there, and your patient will receive the medications in the mail within 2 to 3 days. So that really makes it accessible if you're in a place where a local pharmacy is not carrying mifepristone, and really anybody could receive the medications from Honeybee no matter what state they're in. So another interesting thing that I learned through preparing this talk was just really understanding the prevalence of the misoprostol only medication abortion approach that is used all over the world. Women in Brazil are sort of celebrated for having discovered this, that misoprostol was available at the pharmacy and they could terminate pregnancy by going and picking up some misoprostol without any restrictions. So the international studies of people who use misoprostol only for either for self-managed abortion or through a medication abortion that's managed by a medical provider are pretty astounding. The efficacy is much higher than I would have thought. It is officially approved sort of by the World Health Organization up to 10 weeks, but it is used for, I saw data up to 23 weeks. So, and I think the key to the efficacy compared to a single dose of misoprostol, 800 micrograms, which gets you sort of like an 85% effective rate of total expulsion of the pregnancy. If you do repeated doses of misoprostol 3 times, 3 hours apart, the efficacy is very, very good. The international studies in a JAMA Open Network article showed mostly above 95% to 100%. Again, somewhat dependent on the gestational age. So for patients internationally and also for patients here in the United States who may not be able to access mifepristone, that is also a highly effective and safe option. Interestingly, the World Health Organization recommends that, that people have access to misoprostol for self-managed abortion, which I'll talk about in a second. So then moving along to the official FDA-approved regimen of mifepristone and misoprostol, it is approved for use up to 10 weeks in pregnancy. And that is a standard 200 milligram dose of mifepristone, followed by 800 micrograms of misoprostol, which can be used either buccally or vaginally. And then the timing of the misoprostol can be, it's somewhat dependent on the route of the misoprostol that you choose to use. And the efficacy is very good. I was actually surprised to see that it is only 93%. This is what NAF shows in their efficacy table. 93% more or less at 8 to 9 weeks. And I'll say that now looking at the second dose of misoprostol, which is recommended for use at, it's recommended that it be offered at 9 weeks and then officially prescribed at 10 weeks gestation, that it really, really increases the efficacy. It makes me think maybe we should be offering a second dose for the earlier pregnancies as well. So then I jumped ahead to my last column, which is mifepristone with a repeat 2 doses of misoprostol. And that can really increase, take that 92.3% efficacy at 9 to 10 weeks that you get with a single dose of misoprostol. If you add a second dose of misoprostol, you're really up to like 99% effective at 9 to 10 weeks. So it is uncomfortable for patients to use misoprostol. There's lots of cramping and bleeding. It's not something that you would prescribe willy-nilly, but I have seen that in some of the self-managed abortion protocols, there is a second dose, even at earlier ages. And I think that's because they just want to assure effectiveness when people are doing self-managed abortion. So talking to patients about what to expect during their medication abortion, it's really important to give people graphics whenever possible. People get information overload when you're describing the steps of the procedure to them, giving them written information, and also websites for support, which I can share with you later. When we give mifepristone in the office or people take it from the pharmacy, there are usually no symptoms that go along with that. Occasionally, people will start bleeding, but it's important to reinforce it's still necessary to go forward using the misoprostol as you describe. People take the misoprostol anywhere from 6 to 48 or 72 hours after their mifepristone, and can have some low-grade fever, myalgia, nausea, vomiting, and diarrhea, and usually have onset of vaginal bleeding and cramping within 30 minutes to up to 4 hours. And we tell patients that heavy bleeding can last about 1 to 4 hours after taking the misoprostol. They may be able to take a repeat dose of misoprostol if nothing has happened at 24 hours. And we tell folks that soaking 2 pads per hour for more than 2 hours should prompt a call to the health center. And then usually I recommend that people use their whatever analgesic they're going to use, maybe 30 minutes after their misoprostol or as soon as they use their misoprostol. So complications of medication abortion, as I said earlier in the talk, are really quite uncommon. Heavy bleeding is the #1 symptom. Whether it's a complication really depends on whether or not somebody needs additional care. It's extremely rare to need a transfusion after a medication abortion. Incomplete expulsion of the products is also a possibility. That can be treated with an additional dose of misoprostol. You can just use expectant management, or you can offer an aspiration if it's troublesome for the patient. Ongoing pregnancy is not very common, but is possible, and you can offer procedural abortion or an additional round of mifepristone and misoprostol. And infection is very, very rare. There were some unusual infections in the early years of medication abortion, about 20 infections with a rare form of Clostridia, but those have not been seen for a very long time. So infection after medication abortion is very rare, and we don't give antibiotics routinely for medication abortion. Follow-up plans are also very achievable, either by telephone or in person, depending on what your patient's capacity and their preferences. Really, we piloted this in during COVID, that a telephone call to a patient to have them self-assess their pregnancy symptoms, tell the story of the heavy bleeding and cramping. Did the timing seem right? Did the early pregnancy symptoms they have disappear? And then you can follow up with a single beta HCG at 6 to 7 days, and you're looking for an 80% drop by that time. That does require you to draw an HCG on the day that you see the patient in the office, or that you talk to them on the telephone. So that is a little bit of a barrier. You can also do a follow-up ultrasound just to look and make sure that there is no gestational sac. The presence of what we call schmutz in the uterus is not a reason for aspiration or repeat misoprostol unless it's troublesome to the patient. And then for patients who self-manage or who do telemedicine abortion, they're recommended to just do a pregnancy test at home at 3 to 4 weeks to assure that they are no longer pregnant. One of the things that I learned about that I really was not knowledgeable about before preparing this talk was self-managed abortion. So the WHO actually recommends that self-managed abortion should be available as a non-invasive, cost-effective, and autonomous procedure. And this is a little hard for healthcare providers to wrap their head around, but really what it means is that patients find medication, assess their own eligibility for taking the medicine using questionnaires or checklists. They self-administer the medication, and then they self-assess the success of the procedure. The legality of this is a little bit unclear, especially if you're in a state where abortion is illegal. Many states say they do not pursue patients who have had the abortion. It's really the system or the providers who are doing it, but it is kind of a legal gray area. People access mifepristone and misoprostol, as well as a misoprostol-only regimen for self-managed abortion. And as you've already heard, those are very highly effective. And I saw through Aid Access that they routinely recommend a second dose of misoprostol for all patients 3 hours after the first. And I didn't see it written, but I think that is to kind of bump up that effectiveness to make sure that people who are doing self-managed abortion can actually complete the procedure on their own. And at the end, I'll give you a scan code. I have a whole list of resources, both for patients and providers. For people who are doing self-managed abortion, they can access that through programs like Aid Access or Plan C pills, which are online. There's a miscarriage and abortion hotline for people who are undergoing the procedure in the moment and who need advice or support. And there's also free legal help for people who are self-managing abortion. And all of those resources will be available to you. So the take-home points that I hope you will get from this talk are that both the one drug with misoprostol only and the 2-drug regimens with mifepristone and misoprostol are highly effective, remarkably safe, safer than pregnancy and safer than a shot of penicillin. Pregnant patients can access medication abortion through online in-person medical visits, through in-person medical visits, through online telehealth visits, and through informal networks where no physicians are involved. And if you're currently managing patients during pregnancy, including those who have pregnancy loss, you already have all of the medical knowledge and likely have a network of care, including someone who could do aspiration if you wanted to begin providing medication abortion. And just a message from the front line. One of my mentors and friends, Panalasi, is working for the miscarriage and abortion hotline, talking to patients who are in the process of having a medication abortion. And she sends out a plea for you to consider providing medication abortion unless you are somewhere where you can't. Even if you're not able to do medication abortion, considering looking at your system and seeing how you could expand access to patients who just need help assessing where they are in an early pregnancy to know what their options are so they can seek care online or through self-managed abortion. And that you can develop a list of resources for your patients who are seeking abortion, even if you don't provide it anywhere in your community or in your practice. So the last thing is that there's a little scan code that can get you to all the resources and links that I talk about here. There are links for patients, as I talked about, and there are also resources for providers who are in practices where you currently aren't doing medication or procedural abortion. There are grants to help practices begin doing that, understanding how to bill Medi-Cal or Medicaid. So if you have the inclination, you can find all those resources on my resource page.
Fantastic, Tara. That was just so great, so rich. And I think I speak for much of our community when I say we're just so fortunate here to have so many leaders in abortion care coming from our immediate community. You obviously at the top of that list, and Panalasi and many other people who are online today. So just really, we are really fortunate. I have a quick question, and I also want to just point out that we're going into our break time right now. So if people need a bio break or something, the next talk will start in about 9 minutes, but we'll stay on the line so Dr. Scott will be able to answer questions. But I have a quick question, two of them actually. One is about the prescriber requirements for MIFI, and I think this is probably an obvious answer, but is that mostly just a political thing that it's, yeah, you're just shaking your head, yeah. So it's basically just political. It's not like there's anything scary about this medicine that somebody who's already not doing this, not providing abortion care, needs to be like, oh, I need to do XYZ before I
No
start.
CME required. When the FDA approved mifepristone originally, they gave it a REMS status, which meant because if it got into the wrong hands of a person who was pregnant and didn't want to end a pregnancy, it could be considered dangerous. There's nothing beyond that that is dangerous about mifepristone. So it got this kind of higher level of requirement, and the manufacturer, Danco, basically has a one-page piece of paper that you have to sign, and it's really easy. I have a resource in there to how you can do that. It's really very ceremonial.
Terrific. And then a quick question about that really high dose misoprostol protocols using up to 2,400 milligrams in the course of a few hours. Side effects with that, nausea, et cetera. Do you got a plan for that? A little bit more fever?
Interestingly, I think for when you look at the international studies where people don't have other options, the qualitative data from patients who use those, it is considered highly acceptable. For people who are used to a higher level of healthcare, that I think it is less tolerable for patients in the United States for many. But yes, it is, I'd say one provider I was talking to said, oh, that sounds so miserable. But misoprostol is kind of a tough medication to take at those doses and can cause more like a prolonged uncomfortable day.
Great. Anybody else have questions for Dr. Scott? We have so many experts on the line, so people really know this topic well.
The the thing that, there's one question here about how ultrasounds are used with
Yeah.
medication abortion. So ultrasounds are not used with telemedicine abortion. Telemedicine utilizes patient recall of LMP, provider-patient conversations about pregnancy symptoms, and no ultrasound required. That was really scary during COVID when we went to the telephone-only model. And really, the data from the COVID era showed that it was really very safe and effective in a very small number of patients who improperly assessed their gestational age.
Right. Well, I will just remind people again that we have about 5 minutes until we start our next talk. So we'll keep the chat line open. So if people want to jump in and ask questions of Dr. Scott or anybody else who's spoken today, chat among yourselves, etc. I'm going to put in a screen share here with some details for people to see. And yeah, please take a break, and we'll see you again in 5 minutes. But again, the line will remain open.